For this lecture, I will be discussing the most common autoimmune diseases. So these are the learning objectives for today's topic. So your competencies would actually involve you to be able to know the basic pathophysiology of the following autoimmune diseases. So you have SLE, Graves' disease, rheumatoid arthritis, Addison's disease, and diabetes mellitus. Although there are actually a lot of autoimmune diseases, but my discussion will revolve on these common diseases. Autoimmune diseases actually involves the breakdown of the immune system's ability to discriminate between self and non-self, and the body's immune system therefore mounts immune reaction against self-antigens with harmful effects to the individual. Normally, your immune system is able to tell which are self and non-self components, such that your immune system do not normally mount any immune response to your self-antigens. However, in autoimmune diseases, what's happening is that your immune system could not actually discriminate between your natural or innate self-antigens with that of non-self antigens. Therefore, it mounts immune response, no? Even to your self-antigens, causing detrimental consequences to the body. So this refers to conditions in which damage to the organs or tissues results from the presence of autoantibodies or autoreactive cells. So I have mentioned that your immune system, okay, considers your self-antigens as non-self in autoimmune diseases, such that it mounts immune response by producing antibodies. We term these antibodies autoantibodies because they are actually attacking your self-antigens. No? That's why we term it as autoantibodies. Now, autoimmune diseases affects 5 to 7% of the population and are thought to be caused by the loss or breakdown of self-tolerance. Now, when we talk about tolerance or self-recognition, okay, in this normally refers to the lack of immune response to self-antigens. And this is usually initiated during fetal development. So normally, your immune system do not attack your own cells, do not attack your own antigens. They could actually tell or discriminate which one is self and non-self. However, in autoimmunity, there is actually a loss of this what we call tolerance or self-recognition, okay? Such that there are actually defects, okay? Defects during the fetal development of these cells now responsible for self-recognition or tolerance, such that they tend now to attack or mount an immune response to your own cells or self-antigens in autoimmunity or autoimmune diseases. Now we have two types of tolerance. We have this what we call central and peripheral tolerance. So central tolerance develops in thymus during fetal life. So this is actually responsible for fetal immunity, whereas peripheral tolerance is a process involving mature lymphocytes and occurs in the circulation. So this is the tolerance that you develop all throughout, no? As you age day by day, okay? As your lymphocytes or your immune cells are being exposed, constantly exposed to different types of antigens. So they learn now, they learn an immune response such that they know now which one is yours, okay? Self antigens versus that of non-self antigens. So we call that peripheral tolerance. Now, autoantibodies normally are not all are actually detrimental to the body because normally they function to a certain antigen to get rid of dead cells and defective self-antigens. They form complexes which are then rid of from the body. So normally your autoantibodies has a function. Okay? Now they tend to act in immunosurveillance such that when your immune cells now would actually detect that this self-antigen is defective or non-functional and this may cause harm to the body, your autoantibodies would actually attack those self-antigens and for it to be eliminated. But in autoimmunity, okay, even if these self-antigens are actually functional or not defective, there's actually a mounted immune response, no, such that your body now could not discriminate anymore which ones is functional or not. So they just attack, no, any self-antigens they could encounter. Okay? So auto-antibodies in autoimmune disorders are present and damage to organs. There is an organ damage. Now, these are the factors that influence development of autoimmunity. We have genetic factors, although not well established, but in some cases, there are a lot of genetic predispositions. So, such that autoimmune disorders are more likely in women than men. Okay. For example, in systemic lupus erythematosus, which has higher predominance in women compared to men. Presence of certain HLA, okay, for example, in rheumatoid arthritis, which is more or less associated with HLA-DR3 and 4, okay, and then older patients actually are more likely to develop autoimmune disorders. Exogenous factors such as drugs, ultraviolet radiation, and chronic infectious disease, which might cause mutations, okay? Mutations to the genes that regulate development of your immune cells. Now, we have this what we call immunopathogenic mechanism, okay? Immunopathogenic mechanisms, which actually contributes to the development of auto antibodies or autoimmunity. So we have this what we call sequestered antigen or hidden antigen theory, wherein they propose that a certain antigen are hidden within the organ which escapes the detection by the immune system during fetal development, or there was no tolerance that was developed for it. Okay? However, when the antigen escapes to the circulation, the immune system now detects this and sees it as foreign. So, hidden antigen theory, in simpler terms, would mean that there is a certain antigen which are considered defective, which were not detected initially during fetal development, no? Immune cells during fetal development. And so, when they are now detected, okay, as the person ages, when they are now detected, your immune system would now able to mount now an immune response producing autoantibodies directed to these hidden antigens. Then we have another theory, no, which they term as altered antigens. These arise from biological, chemical, or physical processes. Okay? So by altered, we actually mean that normally your self-antigens are produced, no? Normally such that your immune system could see this or discriminate these between self and non-self antigens. But due to exposure to some agents, for example, UV radiation or drugs, this causes alteration in these self-antigens now, such that they become now defective and so autoantibodies are produced against them. Then we have this what we call foreign antigen theory, where shared or cross-reactive with self-antigens or tissue components occur. Okay? And then we have mutation and loss of the immunoregulatory function by the T lymphocyte subsets. Now, in total, autoimmune diseases may be classified according to its manifestations, okay, involvement. It may be organ-specific or systemic. Organ-specific if it affects only a particular system of the body. Systemic meaning it involves more organs, no? So, for example, in systemic lupus erythematosus, which in a complicated cases may actually involve the skin, the joints, the kidney, brain, heart, and lungs. Okay? Whereas for organ specific, we have Hashimoto, no, which and Graves' disease, which affects the thyroid, pernicious anemia affecting the stomach, okay? The gastric cells, no, particularly parietal cells, Addison's affecting adrenal glands, and etc. Now, these are the common, okay, autoimmune diseases with their corresponding autoantigen and the effects when an autoantibody are actually directed to these autoantigens. So we have immune hemolytic anemia, okay, wherein the autoantigens are actually found on the surface of the red cells. And so when autoantibodies are directed to these surface antigens in the red cells, this causes now lysis or destruction of the red cells via complement-mediated destruction. Then we have autoimmune thrombocytopenic purpura, wherein there are defective surface glycoproteins in the platelets, okay? Defective glycoproteins in the surface, embedded in the surface of the platelets. And when these are detected by your immune system, it mounts now an immune response producing an autoantibodies directed to these platelets, defective platelets. And so this causes now destruction of your platelets, leading now to abnormal, okay? Abnormal bleeding. So thrombocytopenic purpura. And then we also have good Pasteur syndrome, wherein your immune system actually would mount an immune response against the collagen that makes up the basement membrane of the glomerulus. And so when these autoantibodies would actually form complexes or attack these collagen, the basement membrane, this may cause glomerulonephritis and pulmonary hemorrhage. Okay? Now, we have pemphigus vulgaris. The autoantigen there is the cadherin, okay, causing blistering of the skin. Rheumatic heart fever, okay, acute rheumatic heart fever in which the main pathophysiology is by molecular mimicry. So your group gas now, group A streptococci, okay, your group A streptococci would actually produce on its surface a protein which basically have the same, okay, the same structure to that of antigens found in the cardiac muscle. We call that protein M protein. And your body now could not actually tell, no, whether this cardiac muscle now protein is the self antigen or whether it's the M protein by the streptococci causing streptococcal infection. And so it mounts an immune response by producing autoantibodies now causing myocarditis or defect or dysfunctional heart valves. Then we have Graves' disease, wherein the autoantibodies are directed to the receptors of thyroid stimulating hormone. Okay? So this results to hyperthyroidism, and then when autoantibodies are now directed to the acetylcholine receptors, this produces hypotonia, no, or weakness, body weakness, because remember the action of your acetylcholine is to actually produce or to act on neuromuscular junctions, thus causing neural excitation. Okay? That is usually seen in patients with myasthenia gravis. And then we have type 1 diabetes mellitus, okay, wherein the antibodies are directed to insulin receptors. Okay? Now, when these antibodies now destroy or cause destruction of these insulin receptors, the glucose now could not be taken up by the cells for usage. And so this results to hyperglycemia and ketoacidosis. Now, another autoimmune diseases common. Okay, autoimmune diseases are as follows. Now, a common, very common, okay, systemic autoimmune diseases is your lupus erythematosus, wherein your DNA, okay, the substances that makes up your DNA are considered foreign by the immune cells, and so they mount an immune response producing antibodies specific for these components. So we have antibodies against DNA, histones, ribosomes, okay, snRNP and scRNP. May actually many, no, many antibodies. So this may result to a lot of consequences involved in systemic lupus erythematosus, depending on which organ these immune complexes lodge to. Okay. Then we have rheumatoid arthritis, wherein autoantibodies are produced against joint antigen, synovial joint antigen. And so this would eventually lead to formation of pannus, leading to joint inflammation and synoviocyte destruction. And then in multiple sclerosis, okay, and autoantibodies are directed against myelin, okay, components, particularly the proteolipid protein component. And so this causes neural or brain degeneration and paralysis. So I've mentioned this already, no? Some other thyroid gland autoimmune diseases, aside from Hashimoto and Graves, we have thyroiditis, acute thyroiditis, idiopathic hypothyroidism, and then those involving autoantibodies directed against beta cells, no? The islets of Langerhans may be insulin dependent or insulin resistant, causing diabetes. And then for those involving the adrenal gland would actually result to adrenal insufficiency, okay, or Addison's disease. So let's start with a very common, okay, autoimmune disease. We have your Graves' disease. So basically it's a disorder wherein there is an overproduction of your thyroid hormone. Okay? This overproduction of your thyroid hormone eventually leads to hyperthyroidism because you have a lot, no, high levels of your thyroid hormone. This consequently cause enlargement of the thyroid and other symptoms associated such as exophthalmos, heat intolerance, anxiety, and among others. Now, the TSH receptors, okay, the TSH receptors normally is where your TSH produced by the hypothalamus binds to. But in Graves' disease, there are autoantibodies which occupy TSH receptors, and these autoantibodies actually mimics the action of TSH, and so producing a lot, no, or at least high levels of T3 and T4. Okay, so the antigens here implicated are thyrotropin receptors, thyroid peroxidase, and thyroglobulin, and autoantibodies that I've mentioned a while ago mimic the action of your TSH. So before I discuss the pathophysiology in Graves' disease, let's review first, okay? You have learned this in physiology. Let's review first the hypothalamic pituitary thyroid axis, okay? How or how does your hypothalamus now affect production of thyroid hormones by the thyroid gland? So normally, your hypothalamus is the one responsible for producing TRH or thyrotropin releasing hormone. Now, this thyrotropin releasing hormone in turn acts on the anterior pituitary gland, stimulating it to produce another type of hormone we call TSH or thyroid stimulating hormone. Thyroid stimulating hormone now basically has a specific receptor to which it binds to, and that is basically found in the thyroid gland. So the thyroid gland is full of thyroid follicles, which are the basic units of thyroid hormone synthesis. The thyroid follicles are surrounded by a lining of follicular epithelial cells and contain an acellular lumen full of proteinaceous material termed the thyroid colloid. Okay? So if this is the thyroid follicular epithelial cell, what's inside the thyroid follicular cell are actually a proteinaceous material, okay? Proteinaceous material which we term as thyroid colloid. Now, synthesis of thyroid hormones actually is a multi-step process which occur within the follicular epithelial cells and within the acellular follicular lumen. So let's have a brief review on how these thyroid hormones are produced and which components are actually attacked by these autoantibodies now, leading to manifestations of your Graves' disease. Now, normally for thyroid hormone synthesis, we need a lot, large amounts of iodine are needed for synthesis of physiological levels of thyroid hormones. Now, to generate sufficient concentrations of iodine, the ionic form of the atom, iodide, here now, iodide is actively transported from the bloodstream into the follicular lumen by the follicular epithelial cells. Consequently, iodide is highly concentrated in the thyroid gland compared to the rest of the body. Okay? So, the prerequisite molecule now for thyroid synthesis is actually your iodine. Okay? And this iodine is transported in the form of an iodide. Now, thyroglobulin is a protein that contains large numbers of tyrosine amino acids that go on to become individual thyroid hormone molecules. Now, thyroglobulin is synthesized within the follicular epithelial cells and secreted into the thyroglobulin lumen. Okay? Now, an enzyme called thyroid peroxidase present in the colloid, a cellular colloid of the follicular lumen. So this is the follicular epithelial cell side and this is the lumen. Okay? The colloid we're in. The colloid where the synthesis basically happens. Now, thyroid peroxidase is found in the colloid. Okay? It converts iodide ion into an I2, okay? Diatomic iodine, oxidizing iodine ions present in the follicular lumen. Thyroid peroxidase organifies the generated iodide by covalently linking it with the tyrosine residues found in the thyroglobulin. Okay? So when we say of organification, this would actually mean linking or binding of the diatomic iodide ion to the tyrosine contained in the thyroglobulin. And this process or organification process is catalyzed by the enzyme thyroid peroxidase. Now we term it as monoiodo, okay, MIT, monoiodotyrosine if it contains one, okay, one iodine residue. We call it DIT or diiodotyrosine if it contains two iodine residues. Now the peroxidase, okay, then combines MIT and DIT to generate T4 or T3 species within the thyroglobulin protein. So we call it now coupling. What enzyme is responsible for this? The thyroid peroxidase. Such that MIT, when it couples with DIT, it produces now T3. When DIT couples with another DIT, it produces now T4. Okay? Now, notably, no, some MIT and DIT residues do not get coupled, and so peroxidase processed thyroglobulin will retain some MIT and DIT residues. So you have now T4 and T3, okay, in the thyroglobulin. Now, peroxidase processed thyroglobulin is then endocytosed by the follicular epithelial cells on a regulated basis. Whenever the thyroid gland is stimulated to release thyroid hormone into the circulation. Now, importantly, peroxidase processed thyroglobulin within the follicle can act as a reservoir for thyroid hormones in the absence of stimulation for hormone release. Okay? Now, once the endocytose peroxidase process thyroglobulin, endocytose in the follicular epithelial cell, the thyroglobulin is broken down by lysosomes, thus releasing the attached T3 and T4. Also the attached, uncoupled MIT and DIT. T4 and T3 are transported out of the follicular epithelial cells and released into the circulation. The iodine atoms MIT and DIT are salvaged and transported back into the follicular lumen as a free iodide ion. Okay? So we recycle the iodide residue not coupled with tyrosine. Okay? Now, in Graves' disease, this is what happens. Okay? So I mentioned already that Graves' disease is actually due to the presence of autoantibodies that stimulate the glandular function resulting in hyperthyroidism. Now, there are actually autoantibodies against the TSH stimulating hormone receptors. A long-acting thyroid stimulator or LATAs binds the TSH receptors and stimulates the thyroid hormone production. So upon binding, it stimulates thyroid hormone production. Now, the thyroid growth stimulating immunoglobulin or this autoantibody stimulates the growth of the thyroid follicular epithelium, okay, leading to enlarged thyroid. Now, autoantibodies that compete for TSH, for binding to TSH receptors, are now called TSH receptor autoantibody. These autoantibodies blocks the receptors, TSH receptor site, and blocks TSH action and stimulates the cell through TSH receptors. So once blocked, now the receptor is blocked, it produces a lot of hormones, and so this leads to increased production of T4 and T3. And so when there is increased production of T4 and T3, what's likely to happen is that it causes increase increase in size or enlargement of thyroid gland, and eventually, okay, um, this leads now to this autoimmune disorder we call Graves' disease. Okay, wherein this is characterized by a raised or high T4 and T3, a raised FT4 and FT3, a TSH of very low, okay, and an increased radioiodine uptake. So these are the signs and symptoms associated with Graves' disease. We have common, no? Common sign effects of your increased levels of thyroid hormones. We have palpitations, tachycardia, and arrhythmias. Okay, sometimes AFib, heat intolerance, increased appetite, and among others. Now, I've mentioned this already, no? Since there is uncontrolled activation of your receptors by the TSH autoantibody receptor, TSH receptor autoantibody, okay? So you get to have increased production of your thyroid hormones, no? Leading to an elevated level of T3, T4, FT4, FT3 in the circulation. However, there is these increased levels of T3 and T4 would actually give a feedback, no, the hypothalamic feedback to stop producing TSH because there is already a lot of these hormones, thus leading to low TSH levels. Now, we call these antibodies now thyroid stimulating immunoglobulin, okay, or the LATs, no, long-acting thyroid stimulating antibodies, okay. Anti-microsomal antibodies are found in 60% of cases, and anti-thyroglobulin antibodies are found in 30% of cases. Now, in a clinically suspected cases, only the following tests are sufficient: TSH and FT4, no, and also radioiodine. So another autoimmune disease involving thyroid is what we call Hashimoto's disease. Now, it's an autoimmune disease wherein there is damage to the thyroid mediated by producing autoantibodies against the thyroid proteins, notably the thyroglobulins and thyroid peroxidase. So what happens in Hashimoto, if we go back into this, take a look at this diagram, there are actually autoantibodies which are directed to the thyroglobulin and the thyroid peroxidase. Remember, the defect in Graves' disease is just on the receptor, no? TSH receptor found on the surface of the molecular epithelial cell. But in Hashimoto, the defect is in here, the thyroglobulin, okay, and thyroid peroxidase due to autoantibodies directed to these substances. Okay, so hypothyroid, this results to decrease, no? Since there is now decreased levels of your thyroglobulin, decreased levels of thyroid peroxidase, this would eventually lead to decreased production of your thyroid hormone, and so eventually resulting to hypothyroidism. Okay, so common symptoms are here. Now, lab findings are as follows. So if we test for the different hormones, we get to have low, no? Low levels of your T3 and T4 and high levels of your TSH, high to normal levels of your TSH. And if we detect autoantibodies, okay, we would actually detect, no? An autoantibody is directed against thyroglobulin and thyroid peroxidase and some microsomal autoantibodies. Okay? So this is what happens now. So normally, thyroid, okay? Okay. This is your normal thyroid looking gland. Normal looking thyroid gland. And so when autoantibodies, common autoantibodies that I have mentioned, no? Antimicrosomal, antithyroglobulin, antibody to a TSH receptor, antibody to iodine transporter, and some autoantibodies against thyroid peroxidase. This causes now an antibody-dependent cytotoxicity and destruction of your thyroid parenchyma and lymphoid infiltrate, thus producing a hypocellular thyroid gland, leading to Hashimoto's thyroiditis. These are the okay, commonly observed symptoms of patients presenting with hypothyroidism. Now, these are the targets, the autoantigens targeted by the autoantibodies, okay, and its corresponding test. Okay, so we have T3 and T4 determination, okay, by RRA or electrophoresis. Colloidal antigen using indirect immunoassay, thyroglobulins, okay, we may make use of these methodologies, microsomal antigen and thyroid membrane receptors. So, as a summary, okay, this is how you interpret a thyroid panel test when given such. So we have hypothyroidism, usually is characterized by decreased T3 and T4. Why? Because there is destruction of your molecular cells, and some other components such as thyroglobulin and enzyme TPO, which is actually needed for synthesis of your thyroid hormones. And so this now eventually leads to decreased production of your T3 and T4. Now, since there are decreased levels of these hormones, what's likely to happen is that your hypothalamus would actually respond, okay, via a positive feedback mechanism wherein it produces more TRH. More TRH would mean more stimulation of the anterior pituitary gland to produce TSH. Now, more TSH would actually is characteristic. Increased levels of your TSH is characteristic of your hypothyroidism. Ironically, okay, in contrast to hyperthyroidism, since there is hyperactivity of your follicular epithelial cells due to stimulation by an autoantibody directed to TSH receptor, which mimics the action of your TSH, there is likely increased production of your T3 and T4. Now, this would actually give a negative feedback to the anterior pituitary gland and the hypothalamus, and so causing decreased production of your TSH in hyperthyroidism. The same goes with Graves' disease. Okay? Then another autoimmune disease is this what we call diabetes mellitus, particularly type 1. Okay. So this is also known as insulin-dependent diabetes mellitus, juvenile onset diabetes, diabetes before 30. This basically involves disruption of beta cells in the pancreas. Okay. Now, autoantibodies are actually directed to B cells, leading to its destruction. And so destruction of your B cells, which are responsible for production of insulin hormone, this would actually cause your B cells now not being able to produce insulin, and so or sometimes there are actually instances wherein there is destruction of insulin receptors. And so what's likely to happen is that glucose now could not be utilized by the cells now for energy, okay? Energy production. And so there is accumulation of your glucose in the circulation leading to hyperglycemia. And since your body could not actually use glucose as a source of energy, what's going to happen is that it finds an alternative sources, leading to fat breakdown or fat or lipolysis, okay, fat usage or consumption. This may, eventually lead to ketoacidosis. So the associated HLA type are DR3, DR4, DQ2, and DQ8 antigens. So clinical findings include presence of autoantibodies such as anti-insulin, anti-islet cell antigen. Okay? And since there is defective insulin production, what's likely to happen is that you need to maintain an insulin injection. Okay? Now, these are the genetic contributors to the development of type 1 diabetes mellitus. Okay? So under the cluster of chromosome 6p21, and individuals either have DR3 or DR4 or DQ8. Now, other genes involved are CTLA4, PTPN22, and AIRE. Also, environmental factors play a role, for example, in viral infection, since virus might share epitopes with islet antigens and immune response to virus results in cross-reactivity and destruction of islet tissue. Okay? Hence the term molecular mimicry. Now, islet autoantigens that are targets of immune attack may include your insulin, your beta cell glutamic acid decarboxylase, and islet cell autoantigen 512. So this diagram summarizes briefly the pathophysiology for type 1 diabetes mellitus. Okay? So several predisposing factors would actually lead to formation of autoantigens. Okay? Autoantigens on insulin-producing beta cells, and these circulate in the bloodstream and lymphatics. Soon, when detected and processed by immune cells, they mount an immune response, and so there is production of substances that might eventually lead to production of autoantibodies, such that when these autoantigens processed by antigen-presenting cells, okay, these may lead to activation of T helper 1 lymphocytes, leading to production of interferon gamma and interleukin 2. Okay? So this causes activation of macrophages to release interleukin 1 and tumor necrosis factor alpha. And interleukin 2, on the other hand, causes activation of autoantigen-specific cytotoxic T cells. On the other hand, if autoantigens are actually causing activation of type 2 helper cells, this causes the production of the cytokine or interleukin 4, which causes activation of your B lymphocytes to produce islet cell autoantibodies and anti-GAD65 autoantibodies. Now, all of these mechanisms contribute to the destruction of beta cells with decreased insulin secretion. Okay? So another autoimmune disease is Addison's disease. So what organ is usually affected? The adrenals. Okay? So this is called chronic adrenal insufficiency, hypocorticolism, or hypoadrenalism. There is also noted adrenal atrophy, no? Okay, as seen in idiopathic autoimmune processes. Now, women are more likely affected than men, no? Twice the times it affects men. And the HLA plus 2 antigens involved are DR3 and DR4. Okay? So the autoantibodies are actually produced, which is directed against the different adrenal cortical elements, and some other autoantibodies which is directed to the different, which causes disruption of your adrenal cells, leading to adrenal insufficiency. So a common clinical finding for Addison's disease is a presence of low serum cortisol and elevated corticotropin, and the presence of the different autoantibodies. So normally, okay, your hypothalamus is the one responsible for producing the hormone, corticotropin releasing hormone, which acts upon the anterior pituitary gland, causing it or stimulating it to produce ACTH, or adrenocorticotropic hormone. Your adrenocorticotropic hormone acts on the adrenal, particularly on the receptors found in the adrenal cortex, leading to cortisol production. When you have enough now cortisol production, it sends a negative feedback mechanism telling the hypothalamus and the anterior pituitary gland to stop producing cortisol. Now, what happens um, in Addison's disease is that you have autoantibodies. Okay, you have autoantibodies which are actually directed to the cells which produce cortisol, leading to hypocorticolism and hypoadrenalism. And since you have low cortisol in Addison's, no, due to the destruction of the different cells caused by autoantibodies, since you have low now cortisol levels, this would actually send a positive feedback to hypothalamus and anterior pituitary to produce more releasing and stimulating hormones for your adrenal cortex to produce more cortisol. Thus, the elevated corticotropin levels. Okay. Now, Addison's disease occurs when the adrenal glands do not produce enough cortisol, and in some cases, the mineralocorticoid aldosterone. Adrenal insufficiency may arise, okay, due to adrenal dysgenesis, meaning the adrenal glands does not form adequately during development. Okay, abnormal formation or abnormal development or maturation of your adrenal glands, or in cases wherein there is impaired steroidogenesis, wherein the gland is present, however, not being able to produce cortisol, or in autoimmune cases, adrenal destruction. Okay, a disease process leading to the gland being damaged. Another autoimmune disease is systemic lupus erythematosus. Okay, it is a chronic systemic inflammatory disease marked by alternating exacerbations and remissions. And the peak age of onset is usually between 20s and 40s, and women are much more likely than men to be affected. Okay. Now, with earlier diagnosis and improved treatments, a 90% 5-year survival rate, no, is common for these patients. And immune response is usually directed against target antigens. No? So you actually have many autoantibodies involved in SLE, such as these autoantibodies. Okay? Now, what I want you to take note are the following. No? A common test that we do in the laboratory to detect these many autoantibodies is via fluorescent, okay? Fluorescent anti-nuclear antibody testing. And results for FANA, F-A-N-A, or FANA, or fluorescent antibody testing includes the following. So we check for the pattern of staining. No? See, if homogeneous, this is usually seen in or caused by anti-double-stranded DNA antibody. Usually, you do not detect any staining in anti-single-stranded DNA. Okay, so common also in other diseases aside from SLE. Now, a speckled pattern, okay, is what you see in anti-SM or anti-RNP. So this is actually diagnostic for SLE. You have a speckled pattern, you detect anti-SM. A finely speckled pattern, okay, or staining, what you see in anti-SSA and anti-SSP. This is usually seen in SLE and Sjogren syndrome, okay? And an atypical speckled pattern is what you see in anti-CL17, okay? Seen in systemic sclerosis and scleroderma, and among others, no, among other immunofluorescent patterns. So when you have autoantibodies directed to many organ systems, okay, this actually produces systemic manifestations depending on which organ are actually affected. So if it affects the skin and the face, this may produce a butterfly rash, no, in the face, or red patches. Or when it affects the heart, it may cause endocarditis or inflammation of the fibrosum or atherosclerosis. And it may if it affects the blood, okay, it causes anemia and high blood pressure. And if it affects the muscles and joint, it may cause joint pain and arthritis. Okay? Or it may affect the kidney, causing glomerulonephritis and among others. Okay? So this is a typical butterfly rash. No? Butterfly rash seen in systemic lupus erythematosus. And these are the different signs and symptoms per organ system, no, associated with systemic lupus erythematosus. So notice the manifestation would actually depend on which organs are affected. No, it depends. It varies from patient to patient. So just to share with you, I had a patient now, no, a pediatric patient which has systemic lupus erythematosus, and when we examine the patient, very typical of lupus, no, we've seen the butterfly rash, and then when we did further laboratory workup, we found out that the patient actually had more or less renal manifestations, no. So the patient presented with a lot, no, glomerulonephritis, okay, presenting with hematuria, proteinuria, and presence of pathologic CAS. Also, that same patient, okay, had gastrointestinal manifestation, okay. So, and also our patient had the manifest aside from gastrointestinal, no, that patient was so luhoy because there was already involvement of the liver and some other joints, no. So the patient has enlargement or repeating edema on the extremities and enlargement of the abdominal girth, no. So we term that as ascites. Okay. So this is a criteria on how we diagnose systemic lupus erythematosus, no. So again, I've mentioned it is important that you know the manifestations because we grade, no, we do a point system to determine if the patient really has systemic lupus erythematosus. So first and foremost, we determine the presence of anti-nuclear antibodies. So usually if the titer is 180 or more, so on Hep2 cells or an equivalent positive test at least once, so we actually can continue or do some workup for systemic lupus erythematosus. Okay, the fever associated with SLE is usually 38.3 or more. The leukopenia associated is defined as having a WBC count of less than 4,000 cells per cubic mm, and thrombocytopenia is less than 100,000. Okay, and some evidence of autoimmune hemolysis, okay, producing reticulocytosis, low haptoglobulin, indirect bilirubin, elevated LDH, and positive Coombs test. Okay, let me explain this. Now, why do you see reticulocytosis? Remember, your reticulocytes are actually the cells, okay, the stage which would eventually mature into red blood cells, mature red blood cells. Now, this is actually the cell, no, which matures from the bone marrow and continues its maturation in the circulation. Which means if you have no, a lot of these reticulocytes in the circulation, that would actually mean increased destruction of mature red blood cells. Now you want to replenish those destroyed red blood cells, okay, by the immune system, and so you need to release more and more reticulocytes into the circulation. Thus, the reticulocytosis seen in autoimmune hemolysis associated with SLE. Now, why the low haptoglobin? Okay, your haptoglobin is actually a transport protein for your hemoglobin. And during hemolysis, when there is increased lysis of your red blood cells in the circulation, your haptoglobin now becomes consumed, no? Because it has to bind to the released hemoglobin from the destroyed or lysed red blood cells, thus being consumed, no, producing a low haptoglobin levels. Now, elevated indirect bilirubin. Okay? So why elevated indirect bilirubin? I mentioned this already in your Clean Chem lecture. Why? It's because when there is increased, okay, increase destruction, circular destruction of your red blood cells in the circulation, what's likely to happen is that a lot of your hemoglobin is converted into unconjugated bilirubin. And this unconjugated bilirubin actually overwhelms the capability or capacity of your liver to conjugate this bilirubin, thus leading to an elevated indirect bilirubin. Now, why elevated LDH? Remember, your LDH are actually cytoplasmic enzymes found inside, no, in the cytoplasm, in the cytosol of your red blood cells. And so increased destruction or lysis of your red blood cells would actually lead to increased release of your LDH and a positive Coombs test. Now your Coombs test would actually determine the presence of your, no, direct man siya, direct. So it would actually determine the presence of the antibodies that are coating the red blood cells, no? Red blood cells. So your Coombs test would actually detect no presence of these antibodies directed against the red blood cells. Now, patient also may manifest with delirium, psychosis, seizure, alopecia, and oral ulcers. Okay, so that same patient that I have mentioned, no, I mentioned to you, was admitted due to fever. Why? Because remember these these patients with SLE are actually immunocompromised. So when we did physical examination, we've seen a lot of oral ulcers, no? Particularly studded with candida, no? So the patient has oral thrush. So the one causing the fever is actually a fungal infection, and so we treated the patient. Okay? So very common in patients with SLE. Now, you may get to see subacute cutaneous or discoid lupus, okay, with the following characteristic lesions, no? Psoriasiform lesion, okay, and acute cutaneous lupus, usually presenting with a malar rash or generalized maculopapular rash, and a pleural or pericardial effusion, pericarditis, joint involvement, and proteinuria, okay, due to kidney damage. And class 2 or 5 lupus nephritis, okay, so it actually depends, no, on the involvement, no, the severity of the involvement of the kidney. So class 2 is termed as mesangial, okay, mesangial proliferative lupus nephritis, whereas class 5 is termed as membranous lupus nephritis. Okay? Class 3 is termed as focal lupus nephritis, whereas class 4 is termed as diffuse lupus nephritis. And of course, presence of anti-phospholipid antibodies, no, APAs, which causes actually destruction of the phospholipid used in PT and APTT determination. And so a positive no levels of this anti-phospholipid antibody or a positive lupus anticoagulant would actually lead to prolonged PT and APTT. Now, this may also lead to low levels of complement protein C3 and C4. Why? Because in lupus erythematosus, there's actually activation of your immune system, and so leads to consumption of your C3 and C4 and some other complement proteins. Thus, the low complement levels. And of course, the presence of the different antibodies, autoantibodies, okay, that I have mentioned a while ago. Now, the laboratory workup, okay, this is an algorithm showing you how we work up patients with SLE or suspected to have SLE. So we first do ANA determination such that a titer of 1:80 or more, okay, would actually be a positive, no, it's actually a positive determination for SLE. And so we apply these additive criteria that I have mentioned. So the additive criteria are the different symptoms and I've mentioned that we grade, no, we do point system. So we have constitutional symptoms of fever, hematologic symptoms, neuropsychiatric, mucocutaneous, serosal, musculoskeletal, renal, antibodies, complement proteins, and SLA-specific antibodies. Okay, we total the number of points such that we classify the patient as having SLA with a score of 10 or more. Okay, if entry criterion is fulfilled. So you do not count a criterion if there is a more likely explanation than SLE. Okay, and what's important to note here is that SLE classification requires at least one clinical criterion, at least one of these clinical criterion, and more than 10 points. Take note, within each domain, only the highest weighted criterion is counted towards the total score. For example, under hematologic, your patient presented with both leukopenia and thrombocytopenia. So you do not add up 3 and 4, no 3 points and 4 points. You only score the highest. So you use just 4 for hematologic, okay? Or in totaling the total score. So again, we classify the patient as having SLE with a score of 10 or more if the entry criterion is fulfilled. So what's the entry criterion? Anti-nuclear antibodies titer of 1 is to 80 or more. Now, another autoimmune disease is rheumatoid arthritis. Okay? So, rheumatoid arthritis is caused by inflammation of the joints exacerbated by the autoantibody no, rheumatoid factor, or also known as the autoimmunoglobulin antibodies. So, this causes chronic inflammation of the peripheral joints, and usually laboratory results are as follows. So we have increased levels of ESR and CRP because usually there is inflammation involved. So increased level of ESR and CRP, and then presence of or detection of rheumatoid factor, which is actually an IgM, and presence of ANA, anti-nuclear antibodies, more or less the same ANA that we are talking about in SLE. Now, a titer of 1 is to 160 is indicative of autoimmune disease. Okay? Now, to discuss briefly the pathophysiology. Okay? So, the earliest lesions in rheumatoid joints show an increase in cells lining, increase in the number of cells lining the synovium, and infiltration of mononuclear cells and mostly CD4 T lymphocytes. CD8 T lymphocytes are actually scattered all throughout, as well as your B cells, okay, which are antibody producing cells. So these autoantibodies now are directed to the cells lining in the synovial lining, no? Producing now inflammation. Okay? Now, approximately 75% of patients with rheumatoid arthritis have an antibody that has been called the rheumatoid factor. So it is most often of the IgM class and is directed against the Fc portion of the IgG. However, this antibody is actually not specific for RA or rheumatoid arthritis, as it is only found in 5% of healthy individuals. Okay, so another autoantibody. Another autoantibody, let me see if it's shown here. Okay, not shown in this diagram, but I want you to note that another autoantibody, no, okay, seen in rheumatoid arthritis are this are antibodies, okay, antibodies directed against the citrulinated proteins which are generated by modification of protein-bound arginine by enzyme peptidyl arginine deaminase. Okay? This family of autoantibodies are detected using acyclic citrulinated peptides or CCP. Hence, the antibodies are called anti-CCP. Anti-CCP is now the lead marker for detection of rheumatoid arthritis because it is much more specific than rheumatoid factor. Okay? So anti-CCP, more specific, no? More sensitive for determination of RA. So I've mentioned this already, no? In rheumatoid arthritis or RA, there is stimulation of your CD4 cells. Now this produces substances which leads to activation of your B cells and T cells, macrophages and endothelial cells. When your B cells and T cells are produced or activated, the B cells would actually release antibodies and T cells will release cytokines, okay, initiating a hyperimmune response leading to formation of immune complexes. When macrophages are activated, they release pro-inflammatory cytokines, okay, as follows, and endothelial cells, when activated, leads to the expression of adhesion molecule causing inflammation to happen. Now, all of these events leads to panos formation, such that the levels of lipids in the synovial membrane is increased as compared to the synovial membrane of healthy individuals. Now, repeated increased levels of this or repeated activation of these immune cells would eventually lead to the manifestations of rheumatoid arthritis. Okay? So this is the ACR or the American College of Rheumatology or EULAR criteria, or EULAR means European League Against Rheumatism criteria for rheumatoid arthritis. So you must have at least one joint with definite clinical synovitis or joint swelling. And plus the additional of classification criteria for RA, which involves the following domains or components. So joint involvement, okay? One large joint would mean a score of 1, 2 to 10, score of 2, and so on. Okay? It depends on the number of joints involved. Now, for serology domain, we determine the presence of the different antibodies involved in RA. We have rheumatoid factor, and I've mentioned already, the citrulinated protein antibody, or the ACPA or the CCP antibody. And then acute phase reactants, CRP and ESR, which are normally elevated in RA. And the duration of symptoms, acute if less than 6 weeks, chronic if more than 6 weeks or more. Okay, so we add all this up, and a score of 6 or more is needed for classification of a patient having a definite rheumatoid arthritis, 6 or more. So these are the other not so common autoimmune disorders, no? So for examination purposes, I want you to familiarize the different organs affected by each, some of these autoimmune disorders and the different immunologic manifestations. Thank you very much for listening.